Hello everyone and welcome to our module on gout drugs. In this video I'm going to talk about the treatment of gout. Acute attacks of gouty arthritis are treated with NSAIDs, glucocorticoids, and colchicine. I talk about NSAIDs and glucocorticoids in a video in the immunology section and I won't review those here, but we will talk about colchicine. And then for patients who have multiple recurrent attacks of gout, they can be placed on preventative therapy to reduce the uric acid level in the body. Drugs that do this are xanthine oxidase inhibitors like allopurinol and febuxostat. There's also a drug called pegloticase and finally probenecid, and we'll talk about all three of these categories of drugs in this video. Colchicine is a drug that can be used to treat acute gout. Colchicine works by inhibiting microtubules. In the cell biology section in the video on the cytoskeleton, I talk about microtubules in general. They are cytoskeleton elements that are made up of dimers of the protein tubulin. An alpha-tubulin molecule and a beta-tubulin molecule come together, and then a series of these dimers form microtubules. What colchicine does is bind to tubulin and prevent the polymerization of tubulin into microtubules. When this happens, white blood cells become inhibited. They cannot migrate into the joints and they cannot phagocytose the uric acid crystals. The main problem with this drug when you use it clinically is the GI side effects. Many patients develop diarrhea, nausea and vomiting, or abdominal pain. And colchicine really is a drug that just has a couple of niche uses, which is high yield for you to remember. So it's used in gout, it's also used in pericarditis, and it's also used in a rare disorder called familial Mediterranean fever. There are two xanthine oxidase inhibitors that can be used for prevention of gout. Those drugs are allopurinol and febuxostat. Both of them inhibit the enzyme xanthine oxidase, which, as I mentioned earlier, converts hypoxanthine into uric acid. So when you inhibit this, you will have less production of uric acid. Allopurinol is a competitive inhibitor. Febuxostat is a non-competitive inhibitor. That's the main difference between the two drugs. Febuxostat is a relatively recent drug on the market. It wasn't available a few years ago. Allopurinol has been around for years. And both of these drugs are given for the prevention of gout attacks. They're also given to prevent tumor lysis syndrome, which we'll talk about in a minute. It's very high yield for you to understand that both of these drugs can abruptly change the serum uric acid level. Now, lowering the level is good, but when you suddenly shift the level from a higher to lower value, that can precipitate gout crystals in the joints and cause a gout attack. So for that reason, anytime you start one of these drugs, you also co-administer NSAIDs or colchicine to prevent patients from developing an acute attack while you're initiating therapy with a xanthine oxidase inhibitor. For many years, allopurinol has been the first-line therapy for patients with recurrent gout attacks. The problem with this drug has always been that a significant percentage of patients cannot tolerate it. The main issue is usually the GI side effects. Many patients develop nausea, vomiting, and diarrhea. In addition, it is metabolized by the liver, so hepatic toxicity can be seen. There's also a hypersensitivity skin rash that occurs in some patients. And then finally, in rare patients, bone marrow suppression occurs. Febuxostat is a newer drug. It's more expensive. It's a second-line agent. It's used for patients who are intolerant of allopurinol. Now, febuxostat still has a significant incidence of these side effects. In particular, many patients still develop GI upset. However, because it has a different chemical structure, it's often tried in patients who are intolerant of allopurinol, and there are many patients who can tolerate febuxostat but not allopurinol. There are two immunosuppressants that interact with the xanthine oxidase inhibitors. Those two immunosuppressants are azathioprine and 6-MP, and I talk about both of these in the video in the immunology section on immunosuppressants. But basically, azathioprine is metabolized into 6-MP, and then they both work the same way to suppress the immune system. But the reason we're talking about them here is because they are both metabolized by xanthine oxidase into an inactive metabolite called thiouric acid. So if you inhibit xanthine oxidase with allopurinol or febuxostat, the level of 6-MP will go up, and that can be a problem. Sometimes this is done on purpose to boost the effects of azathioprine or 6-MP, but it also increases the risk of toxicity. And so for your board exams on step 1, they're going to want you to know that allopurinol and febuxostat will both interact with azathioprine and 6-MP. Next, let's talk about pegloticase. Pegloticase is a drug that has to be administered intravenously. For patients to receive this therapy, they have to go to an infusion center every 2 weeks to get the drug. So for this reason, this is reserved for patients with severe refractory gout. This drug is a recombinant porcine uricase. What this means is that it's a recombinant version of an enzyme called uricase that is found in pigs, and uricase is a uric acid oxidase, and it degrades uric acid. This enzyme is attached to a molecule called polyethylene glycol, or PEG, and by attaching the enzyme to PEG, the half-life is prolonged. That's why you can administer it only every 2 weeks. In addition, by attaching it to PEG, you limit the immune reaction to the drug, and that makes it better tolerated. What pegloticase does is convert uric acid to a substance called allantoin, which is more water soluble and easily excreted by the kidneys. Therefore, when you administer the drug, you get lots of allantoin, it goes into the urine, and the uric acid level will fall. A related drug that is not used for gout is called rasburicase. This is also a recombinant uricase. It also converts uric acid to allantoin, so it will be excreted in the urine. However, rasburicase is not attached to polyethylene glycol. This means it has a rapid on-off action and it's more immunogenic and there's more risk of an allergic reaction. This drug is only administered to patients who have the tumor lysis syndrome and need their uric acid level lowered very quickly. So let's talk about the tumor lysis syndrome. This occurs in the treatment of some malignancies. When you administer chemotherapy and there is rapid cell lysis, this can lead to high serum levels of the contents that were inside the cell. So for example, if a patient has leukemia and a white blood cell count of 100,000 and you give them chemotherapy, all those white blood cells start to die and they spill their cell contents. Some of those contents include potassium and phosphate. So the potassium can lead to hyperkalemia and arrhythmias and death. This is a major problem in the tumor lysis syndrome. In addition, the hyperphosphatemia can lead to the binding of calcium and phosphate, and this can lead to hypocalcemia, which is also a major problem in the tumor lysis syndrome. In addition to hyperkalemia and hypocalcemia, however, hyperuricemia is also a major issue in the tumor lysis syndrome, and this is from the breakdown of purines found inside those cells. Now, usually this doesn't lead to gout because you need chronic hyperuricemia to get gout, but what this often leads to is uric acid nephropathy and acute renal failure. And for this reason, rasburicase is often administered to help excrete the uric acid in the setting of tumor lysis syndrome so patients don't develop acute renal failure. Probenecid is another drug used to prevent gout attacks. It's called a uricosuric drug, and this means that it promotes uric acid excretion in the urine. It does this by blocking the reabsorption of uric acid in the proximal tubule. This is its structure here, and it blocks the reabsorption of uric acid so that more will go out in the urine. A side note here, it also blocks the secretion of penicillin into the urine, and for that reason, it will boost penicillin levels. And in fact, probenecid was originally developed to enhance penicillin effects back when penicillin was the only antibiotic available and some bacteria were resistant. It turned out over time that it also helped in gout, and now it's mostly used for gout. It's a sulfa drug. It has a sulfa moiety in it, so patients who are allergic to sulfa may have an allergic reaction to this drug. And in addition, because it makes more uric acid go into the urine, it can potentially lead to uric acid kidney stones. I'll finish this video by talking about aspirin, which has a peculiar effect on uric acid levels depending on the dose administered. Very high dosages of aspirin, more than 2.6 grams per day, will inhibit uric acid secretion into the urine and reabsorption, and the net effect will be the same as probenecid. The drug will be uricosuric. It will promote uric acid excretion and lower serum uric acid levels. Now, 2.6 grams per day is a huge amount of aspirin. My patients who have coronary disease take only 325 milligrams per day, so it's very unusual that anyone will ever take this much aspirin. At the usual dosages of aspirin, the lower dosages, aspirin inhibits secretion of uric acid only. This means that taking a low dose of aspirin will lead to less uric acid excretion and a higher uric acid level. So for this reason, aspirin is not used for pain control in gout because at the standard low dosages, it will block the secretion of uric acid and raise the uric acid level. And that's just something you have to know about aspirin. It's got this peculiar so-called bimodal effect that is dose dependent. And that concludes our video on gout drugs.